Bismillahirrahmanirrahim. Today we will have case quiz number 101. Case data: 48 years old Caucasian male. He is hypertensive with past medical history of gastroesophageal reflux disease (GERD), irritable bowel syndrome, chronic headaches, anxiety, depression, chronic low back pain secondary to spinal stenosis status, post L3 through L5 laminectomies 12 years ago. The patient had end-stage osteoarthritis in bilateral hips treated by bilateral total hip arthroplasty or total hip replacement with metal-on-metal prosthesis 13 years ago. The patient worked in the construction industry for many years and performed daily tasks that resulted in his chronic hip disease, including heavy lifting and prolonged kneeling. Following the left hip replacement, his pain was vastly improved and he did well with no complications. However, following the right hip replacement, he noted increased bilateral hip pain, right more than left. 10 years ago, I mean 3 years after the hip replacement, he presented with hip pains, increasing confusion, headaches, blurring vision of about 2 weeks, and short-term memory loss. Radiological imaging was performed at that time but failed to reveal signs of joint failure. Blood cobalt level was drawn and returned 11.4 microgram per liter, and the normal is less than 1.8 microgram per liter. He subsequently underwent a revision of right hip replacing metal-on-metal joint with non-metal surface prosthesis. A repeat blood cobalt level was drawn after the surgery and returned to 5 microgram per liter instead of 11.4 pre-operatively. He remained clinically stable following the right hip revision, but few months later, he presented to an outside hospital after he sustained a traumatic fall in his basement. He attributed the fall to symptoms of progressive cognitive decline, including confusion, lethargy, short-term memory loss, and depression, which he noted had worsened since the first hip procedures. CT and MRI scans of the head didn't reveal significant acute pathology. EEG was also negative for seizure-like activity or any other pathological activities in the brain, and all other workups were essentially negative. So, what is the diagnosis? The answer is already present in the slide. It is cobalt toxicity. Cobalt toxicity. Discussion of the diagnosis. The patient described a preceding clinical vignette as an excellent example of a concerning medical topic emerging in the current news. Total hip replacement using implantable metal components is common medical surgery that has been performed in North America for more than 50 years. The goal of total hip replacement is to maintain a functional joint while simultaneously delaying the need for surgical revision or replacement for as long as possible. Nearly 400,000 hip arthroplasty procedures are performed annually in the United States alone, and over the past decade, there has been an increasing trend of utilizing cobalt alloy containing metal-on-metal prosthetic hip joints. Conventional total hip prostheses are composed of metal head that fits into a plastic polyethylene cup. There have been concerns, especially among younger patients, that plastic cup in conventional hip arthroplasty undergo more wear and tear with time and are more likely to require revision. Therefore, metal-on-metal bearings were gained widespread popularity and have been used extensively, especially among younger, still active patients. The benefits of touted by metal-on-metal prostheses is that there is less device wear since cobalt alloy containing metal prostheses have a higher resistance to wear than polyethylene, a decreased risk of dislocation because of new designs and engineering modifications, and decreased risk of device fractures. However, there have been recent safety concerns regarding these prostheses, including excessive revision rates, local reactions to the prosthetic device, and the higher circulating metal ion levels in the patients, which have led to product recalls, a medical device alert, and issuance of clinical guidelines by the United States Food and Drug Administration or the FDA. The biggest concern is that correction, wear, and the other mechanical factors of the cobalt alloy containing metal-on-metal prosthetic procedure, metal debris in the form of wear particles, which subsequently release soluble cobalt metal ion into the joint space and subsequently into the systemic circulation. I mean systemic absorption of the metal cobalt. Over time, deposition of wear particles and the metal ions in the joint space causes gray-black discoloration of the joint and elicits localized chronic inflammatory response, findings referred to as metallosis. Metallosis is not a good thing, as it is often a cause of early prosthetic failure, and the tissue damage resulting from metallosis can compromise subsequent revision arthroplasties. More importantly, though, wear particles from the prosthesis also release soluble cobalt metal ions into the systemic circulation, creating incidentally elevated circulating concentrations of cobalt metal ion in this patient, which is called cobalt toxicity, as in our case. Since cobalt have been shown to be carcinogenic and mutagenic in human and animal models, the potential for systemic toxicity and cancer risk are valid safety concerns for patients with these prostheses, especially most of them are young patients, male or female. Cobalt physiology. Cobalt is an essential transition group metal present in trace amounts in the human diet, notably in fish, vegetables, and drinking water. It is an integral part of vitamin B12 and is required for oxygen transport in metabolism. When ingested, cobalt is rapidly absorbed from the small intestine, but the bioavailability is incomplete and variable. When inhaled through the lungs, usually in the form of inorganic cobalt and cobalt oxide in dust and welding fumes, there is systemic dissemination of cobalt metal ions through the lymphatic and vascular system. Following a single dose of cobalt, the concentration of the blood and serum is initially high, but rapidly decreased to a low level within 24 hours due to the combination of tissue uptake, primarily in the liver and the kidneys and urinary excretion. Studies of whole body retention of organic cobalt in physiologically normal adult human male after intravenous injection demonstrated that approximately 40% of the dose was eliminated within the first 24 hours, 70% by 1 week, and after 1 month 20% was retained only, and after 1 year only 10% was retained. With chronic systemic exposure, however, cobalt accumulates in tissues, again primarily in the liver and kidneys, and the cobalt level will elevated in the serum, whole blood and urine. Following cessation of the chronic exposure, the concentration of cobalt decreased by 51 plus minus 21% and 66 plus minus 29% in the blood and urine respectively. What about cobalt toxicity? Cobalt deficiency has never been described in human, but cobalt toxicity have been well documented. So, it is nearly never to occur cobalt deficiency because it is present even in the drinking water, as I said, and the human need it with very limited concentrations or levels. Cobalt is acutely toxic in large doses and in cumulative long-term low-level exposure, i.e. occupational exposure from cobalt processing plants, hard metal industry, diamond polishing, and ceramic industry. Most of what is known about cobalt toxicity comes from cases of ingestion or inhalation of excess cobalt. For example, a notable historical example of cobalt toxicity is the cohort of patients given cobalt chloride nearly 40 years ago to treat refractory anemia. For some unclear reason, cobalt salts stimulate the production of erythropoietin, and before the availability of recombinant human erythropoietin, cobalt salts were regularly used in clinical practice for the treatment of anemia. However, this practice was discontinued after some patients developed systemic symptoms of cobalt toxicity. The symptoms of cobalt toxicity documented in the literature are variable but typically involve derangements of endocrine, cardiac, and neurological functions, as I will say in the next slide. These are the most important manifestations of cobalt toxicity. Regarding endocrinopathy, the classic endocrinopathy associated with cobalt toxicity is hypothyroidism. According to some sources, hypothyroidism is also considered to be the most sensitive indicator of cobalt toxicity. Cardiovascular dysfunction. A notable toxic effect of cobalt exposure is a severe and often fatal cardiomyopathy. This finding was well documented in the 1960s among heavy beer drinkers after local beer breweries added cobalt chloride or cobalt sulfate to their beer and a foam stabilizer, so-called beer drinkers' cardiomyopathy. Post-mortem studies of the heart in these patients confirmed accumulation of cobalt within the myocardium. Cobalt-induced myocardial injury was also implicated in the study of hard metal workers chronically exposed to cobalt, and another study of Finnish cobalt workers revealed that cumulative cobalt exposure was associated with subclinical echocardiographic changes. What about neurological dysfunction? There are variable neurotoxic symptoms described in patients with presumed cobalt toxicity, including hearing loss, tinnitus, optic nerve atrophy, visual impairment, convulsions, vertigo, headaches, tremors, polyneuropathy, incoordination, cognitive decline, and depression. Unfortunately, most neurological symptoms are highly subjective, but some can be proven objectively, including optic nerve atrophy, audiometry confirmed hearing loss, and abnormal neurological functions illustrated by diagnosis such as EEG or EMG. Skin malady exposure to cobalt can occasionally produce dermatitis, but typically hypersensitivity reactions are less common associated with cobalt than other metals such as nickel. Mechanism of cobalt toxicity. A precise unifying mechanism of cobalt toxicity remains unclear. It has been proposed that many of the adverse effects of cobalt are secondary to its high affinity for sulfhydryl group. Some of the mechanisms proposed include inhibition of crucial enzymes in the mitochondrial oxidative phosphorylation, inhibition of thyroid iodinase, inhibition and competition with calcium binding and signaling, generation of reactive oxygen species, and direct cytotoxicity. But as I said before, a precise unifying mechanism is still unclear. Diagnosis of cobalt toxicity. The diagnosis of cobalt toxicity is based on combination of clinical history and laboratory confirmation. The preferred method of testing is inductively coupled mass spectrometry for metal ion value determination, and the typical patient specimen tested include serum, whole blood, or urine. Cobalt metal ion values are typically reported in units of micrograms per liter. In the blood, cobalt metal ion binds to albumin with an estimated free fraction of approximately 5 to 12%. The more commonly reported value for cobalt metal ion concentration in the serum value is the serum value, which is considered to be reflective of the extracellular fluid levels. Others suggest that whole blood values provide a more accurate assessment of systemic exposure. According to one reference, a serum cobalt metal ion concentration greater than 1 microgram per liter is suggestive of excessive cobalt exposure, and a value greater than 5 microgram per liter is considered likely toxic. However, caution must be applied when testing and interpreting cobalt level in patients with cobalt alloy containing metal-on-metal processes, since these patients tend to have incidentally higher circulating level of cobalt metal ion concentrations, sometimes greater than 5 microgram per liter, but may not have symptoms of cobalt toxicity. It is unclear whether elevated cobalt metal ion levels should be considered toxic in patients with cobalt alloy containing metal processes, especially if they are asymptomatic, since no correlation has been even made between cobalt concentration and physiological effects. Contrastingly, if patient has subjective and objective clinical evidence of systemic cobalt toxicity, has elevated cobalt metal ion concentration, and no history of a cobalt alloy containing metal processes, a diagnosis of cobalt toxicity may be more straightforward. Treatment of cobalt toxicity. There is no consensus regarding the treatment of patients with systemic symptoms of cobalt toxicity, and the clinical response to this treatment is inconsistently documented in the current literature. The main objective of treatment is to eliminate the exposure to cobalt and to treat the systemic symptoms supportively, such as thyroid replacement therapy, beta blockers, angiotensin-converting enzyme inhibitors, ACE inhibitors, diuretics, corticosteroid therapy, and so on. There are no established indications for chelation therapy, and if the cause is metal processes, the final treatment may be replacement, as we see in this case. So, what is the final diagnosis? Elevated blood cobalt levels in a patient with bilateral metal-on-metal hip processes containing metal alloy of cobalt, which is called cobalt toxicity. And finally, thank you very much for your attendance, and we will meet you tomorrow with case quiz number 102. والسلام عليكم ورحمة الله وبركاته.